Welcome to The Pursuit of Health, the podcast on health policy for a free and modern society. Welcome, everyone, to another episode of The Pursuit of Health. I'm your host, Rainer Schur, and joining us on the show today is Emily Kolego. Welcome to the show, Emily.
Thank you. I'm so excited to be here.
So we're having you on today, Emily, on behalf of Sidecar Health. They are a company that is disrupting the health benefits market with their note network plans, which I'm very excited to get into. But before we get into all that, you yourself have a pretty interesting history in how you got to Sidecar Health. So how about telling our audience a little bit about that? Where did you start off in your career and how did you end up where you are right now?
Sure. Well, thank you very much for having me. And yeah, at the risk of aging myself, I realized the other day I've been in Washington now for over 25 years. So I started at the Cato Institute, which is a libertarian, small L, libertarian leaning think tank in Washington, D.C. And I actually started there in the media department and moved into the education policy department. So the first portion of my policy career was more focused on education policy and school choice and issues of that nature. I started as a poli-sci major in college and had a professor that told me this was not going to work out for you. And so to really think about another career. And so I ended up switching to elementary education and I thought I would be a teacher and then an elementary school principal. But anyway, I was at the Cato Institute for a couple of years, and I was working with a congressional office on an amendment at the Education and Workforce Committee, and that congressional staffer was leaving his job, and so I applied and was fortunate enough that they took a chance on me, and so I got the job. And from there, I worked for a couple of members of Congress, and then in 2004. I started working for the Education and Workforce Committee for the then chairman, John Boehner from Ohio. And he, as you may recall, eventually ascended back into the House leadership by becoming the majority leader. And then in 2010, or I guess January of 2011, he became the Speaker of the House. So at that point, I had sort of made the migration into health policy. In 2006, when Republicans lost the majority, we were in the minority for 4 years. I had to sort of pick a path. So, did I want to do education? Did I want to do healthcare? And I chose healthcare. Well, I think I know a lot about healthcare. I feel like there's never enough to know, right? And so I always like to say, like, I'm still always learning about healthcare, but I really was sort of neck deep in all different kinds of healthcare issues when that is the sole issue that you're working on. And then by the time John Boehner became the speaker, I was his health policy advisor until I left my job in 2013, and I joined a consulting firm in downtown Washington called the Nichols Group, run by former Senator Don Nichols from Oklahoma. And I spent about 8.5 years there before moving in-house with an actual client. So I had a client at the Nichols Group called Sidecar Health, and they were a new kind of innovative insurance company. And I was really passionate about the work that they were doing. And so I know we can probably get into more of that, but that's sort of how I went from the Cato Institute then through a couple of different pretty impactful roles, I would say, for my career.
Well, I'm very tempted to ask what it was like to be Boehner's health policy person, but I'm going to resist that
Yeah.
temptation. How about the transition into Sidecar Health? How did you get interested in joining the client side of the business? And
Yeah.
yeah, then tell me a bit more about Sidecar Health.
It probably makes sense to actually talk a little bit about. So I was on Capitol Hill during a lot of different big reauthorizations. So the reauthorization of at the time it was S-chip, and then it became the CHIP program. So Children's Health Insurance Program, that is sort of a public-private partnership or public partnership with the states. And then I was there also for the consideration of the Affordable Care Act.
Right.
And I say that because it was a really important sort of, I think, moment um, for my career in terms of how I think about healthcare policy.
Hmm.
And at the time, because Republicans were in the minority, um, we developed a working group of a lot of different House Republican members to try to come up with an alternative. We did come up with an alternative. It's not talked about a lot, but we did come up with an alternative that actually lowered the cost of healthcare at the time. But it's very difficult in federal health policy making to find new ideas and to certainly find new ideas that don't sort of involve this big carrot and stick. And when I say big carrot and stick, I'm thinking about, big spending items like tax credits or, billions of dollars to create state high risk pools, things of that nature. And so when I was consulting and I learned about Sidecar Health, the CEO actually called me. He was looking for some help with my business partner, and I was looking for some help with CMS and with the first Trump administration. And when he first called me, I thought, wow, this is really, really fascinating because it was the first time I had ever seen something that genuinely reflects market forces
Mm.
that does lower the cost of healthcare. So, just to give a little bit of a background about Sidecar Health, so we are now, at the time it was not, but now in 2022, we became a major medical health insurer. So, we are approved as a large group major medical health insurance plan in the states of Ohio, Georgia, Florida, Alabama, and most recently Texas. And we sell, when I say large group, that think about like employers who have about 51 employees all the way up to maybe 1,000 or 2,000. And so that was sort of our entrance into the employer market. We do not sell anymore in the individual market. We were an off exchange ACA plan for a little bit, but now we are solely focused on the employer market. And what we do is we give consumers information, pricing information, so that they can make decisions about where they want to seek care. We don't have, as you mentioned in the beginning, we don't have some of the more onerous constraints that a traditional insurance plan might have. So we don't have a network, a provider network. We don't have things like prior authorization. We genuinely believe that if your doctor says you need to go get an MRI, you shouldn't have to go get a CAT scan beforehand. Just go get the MRI. And we don't have things like formularies and step therapy. So we give our consumers a Visa card and they can use that card. It connects to our claims account and they can use that card to pay for care at the point of service. And then obviously it works a little bit differently in emergency room circumstances, but we have a website where the consumer can go and they can see the price for anything you can do in the healthcare system. And once you have that kind of information, it's a real game changer. Most of the time, as you probably know, like we don't know what a doctor or office visit costs. I had no idea what it costs to get a physical or a lab test or anything. And now I have some sense about what those prices are. And the providers are choosing that. We're not telling the provider it should be this or it should be this. We tell the consumer what the median price is in any given market throughout the United States. We have customers in all 48 continental states. But we tell the customer what the median price is, and if they want to go someplace that's above that price, it's totally fine. If they want to go someplace below, then they get to keep the difference in the savings. So if it's like $150 to go for a doctor visit and they want to go to a doctor that's $100, we also incorporate quality scores into that. So we're seeing now most customers like to go to doctors that have a 4 or 5 star rating. We get those quality data scores from a company called GAM out of Johns Hopkins. But I say that because I think it's really important because cost and quality in healthcare aren't necessarily correlated. Every time I take my son to the pediatrician, I make $40 from that visit.
Hmm.
And I say that because I love my pediatrician and I believe she has 4 stars based on the last time I looked. But giving consumers a little extra skin in the game so they get to keep the difference if they go someplace that is below the benefit amount. They keep 50% of that. And once the consumer has that kind of skin in the game, it really changes the entire aspect in terms of how you think about healthcare. Then it becomes more like shopping for anything else in your life, right? You know, if you're buying a car or an iPhone or whatever it is, right? Like you know what the price for that should be. And so why would you pay a lot more unless you just really want to? And some people love doctors that are more expensive, but again, that's their prerogative. So I know it was a long-winded answer of what is Sidecar Health, but happy to dive deeper if that's helpful.
Yeah, no, that's a great explanation of Sidecar Health. And I think it's worth stressing for our audience just how innovative and disruptive it is as a concept, like this concept of no network insurance. We here at the Center for Modern Health, we recently posted an article on the No Surprises Act, right, which is about preventing surprise billing. And what we get into that article is that this whole thing about being in and out of network, like it makes sense for insurers to have networks because it's one way that they can keep down the costs with providers. But on the other hand, it leads to so many other problems, like not just
Yes.
surprise billing, prior authorizations, just the whole complexity of things. But then I think when a lot of people hear no network,
Mm.
they might get scared because then they think like,
Yeah.
well, I've always been
You
told
know.
that I have to be in network. Are you
Yes.
saying that I just don't have access to providers anymore? But in some sense, you have access to all the providers. So
Yes.
how how did the whole concept of no network plans even start?
Yeah. So it's a great question. I don't believe we invented the concept of not having a network, but I believe we are probably the only or one of the only major medical health insurance plans that does not utilize a network. There are some more like direct primary care agreements, and we can kind of put that aside for a second. So that is a little bit different in terms of like a monthly membership fee that somebody might pay for something like that. This is different, although similar to a traditional plan in that you're still paying premiums. Your employer might choose that you have a deductible, and that's totally fine. But when you think about paying for care, you don't necessarily, there's this whole, maybe back up for a second. There's this whole concept, as you were sort of alluding to, that networks protect the consumer. But as you know, and as I've done too, occasionally you have to go outside the network because the network's too narrow and you're not able to get the care that you want. Or I just called a month ago for a cardiology visit and they said, we can take you in 2027. That's crazy, right? Like it takes 7 months to be seen. Well, what if I went out of network? So there's a lot of obviously like constraints that go into it. But to your point, how does the consumer know? The company itself started because our CEO had an experience on his own where he had to get an MRI on his back. He had a very generous insurance plan from a company we've all heard of, and he ended up getting a bill for $1,300 after that, which $1,300 in addition to what the insurance company had already paid for the MRI. So let's put that aside for a second. Is that a good price? I don't know. And he eventually had to go back like 6 months later for another MRI. And he said to the nurse, I still haven't hit my deductible. I really don't feel like getting another bill. Is there any other way we could work this out? And she said, well, you could just pay $330 out of pocket. So think about the $1,300 bill or 330 bucks out of pocket. It's the same facility, the same MRI machine. And so it sort of started this light bulb in his mind and our co-founder's mind, who's now our chief operating officer. Could you create a plan that is based on educating the consumer about what things cost and giving them the money to pay for care at the point of service? And when you do that, you don't need a network, right? You don't need to have provider agreements. The provider, especially in that instance, picked the price. Is it a good price? I don't know. I mean, I would say now that I've like know a little bit more about pricing, 330 bucks is actually really good. But it's the same MRI machine in a hospital where they might charge 3 grand and you could go down the street to your local imaging center and it might be 475. But consumers don't have that kind of knowledge. And so now we give them that data. And when you give them that data, as it turns out, 78% of our claims are at or below our benefit amount. So at or below the median price that I was talking about earlier. Because consumers are able to navigate and make smart choices. You sort of alluded to this, and I think this is where a lot of people who think that networks protect the consumer also think that consumers are fairly ignorant and don't have the knowledge to be able to shop on their own. And that's probably true in many cases unless you give them the information that they need. And so we do that on the website. We also have a member care center. Person answers within 2 to 5 seconds. It's an actual human. You don't have to press 16 buttons because we know that obviously seeking out healthcare is hard, but it's also new and different. And so we take a lot of time to educate our customers exactly how it works. So when I go to the doctor, I walk in, especially if it's the first time, and they say, "Do you have insurance?" And I say, "I do have insurance. It's an innovative health plan called Sidecar Health." But again, they don't really even need to know that it's called Sidecar Health. I say, "I'm going to pay today with my Visa card. It connects to their claims account. I just need a detailed receipt so they know what I bought." And they go, "Oh, okay." Now, oftentimes I'll call in advance as well, or I'll look on our website and I can see, okay, down the street, it's going to be $350 or whatever the price is. At Sidecar Health, you can lock in that price, which I think is really important. We do guaranteed pricing for everything in the healthcare system so that there aren't any surprises. To your
Mm.
point at the beginning about like, or the first part of your question about ER services and not necessarily knowing what's going to be covered, which is the other piece of a lot of more traditional plans, might not cover a lot of things that a Sidecar Health plan covers. We don't make those kinds of decisions. If it's medically necessary, you should go get it. Obviously, things that are more like if you want Botox or something because you don't want wrinkles like in your forehead, that's fine. But there are medically necessary reasons that some people might need Botox. And so that's a different situation. But if it is medically necessary, we cover everything. I think it's also important to note that we also cover all the mental and behavioral health
Mm.
aspects. So when you think about, especially in a post-COVID world, a lot of traditional plans have a lot of constraints, or if you're trying to seek out a psychiatrist or some kind of clinician, they say, "I don't take insurance." Well, that's fine. I'm going to pay with a Visa card. I just need a receipt and I'm going to give it to my insurer. And I tell them that too. My son sees sees a couple of different providers for mental health issues related to anxiety and ADHD. And it works great because I get to go to the doctor that we like. I know what the average price is, and he gets the care that he needs, and it's covered by my insurance company. It's actually one of our most popular benefits because we
Mhm.
hear from a lot of people that say, "I've never been able to afford to seek out this kind of care." It also then potentially lowers ER visits. When you think about mental health situations where people might be in more dire straits, sometimes the ER is the only place they can go. And so now that they're able to get that kind of care, we're seeing also a reduction in ER visits, which I think is really exciting because, again, it's not the federal government who often is talking about how do you keep people out of hospitals. This is just an innovative insurance plan that is giving people incentives to make better choices.
On the example of emergency care, yeah, like I
Yeah.
had to have a object removed from my foot,
Mm,
and my wife pointed out like let's not go to the emergency room, let's go to the emergency care center. But we did that because she's a doctor and she knows the
right.
bill will be much higher in the
Yeah.
ER than in the urgent care center. But
Yes.
imagine if I wasn't married to a doctor, right? And like you
Yeah.
don't have that kind of information. But then
You don't.
Sidecar Health does show you that from
Yeah.
beforehand. So
Yeah.
I love that idea. But just a more kind of general
Sure.
question. So the founder did he face any problems in trying to set up this kind of innovative plan? Like was it possible and no one just really thought of it, or were there kind of like policy barriers where you have like I don't know this state insurance commissioner saying like, well, this isn't insurance. We're not gonna
Mm.
give you a license. Like, did you face any
Mhm.
problems like that, or was it more the fact that no one really thought of it?
Yeah, so Sidecar Health started out as, so I would say it's a little twofold. So Sidecar Health started out as we had what was called the Access Plan, which was essentially a supplemental plan. So it was not an ACA compliant plan. It was meant to, like I said, literally supplement another type of insurance product, maybe that somebody else would have from their employer. Or actually, it was pretty popular with also, I want to say, like retirees. So people between the age of like 50 and 64 who maybe like consulted for a while, had a retiree plan, but it didn't cover enough. And so they wanted something else. Um, yes, it does take it did take at the time a little bit more effort, right? So when you are meeting with the state insurance commissioner or any sort of regulator, they often want to put you in a bucket. And so I remember one meeting where they said, well, hold on, you're not an HSA, you're certainly not an HMO, you're not really a PPO either. Like we don't know how to bucket you. And so they said, like, we need to think about this and come back. And sometimes it does, it takes quite a few conversations sometimes to sort of explain to a state. And obviously, and I have a whole team of very smart lawyers that we work with who go through all of the state regulations and point out the reading to them in terms of why we are fundamentally still especially now, a major medical insurance product. So Ohio was our first state. We spent probably 20 months really getting to know Ohio. And again, we had that supplemental plan we were selling in Ohio before we switched to the major medical product. So they had some time to get to know us. And through that experience, again, once you kind of start gaining a little momentum in the market, it sort of unlocks, I think, a lot of other conversations with regulators. But I would say the other thing that we get a lot too is like, well, this just sounds too good to be true. What do you mean you don't have prior auth? How does that work? Like, how do you do utilization management? Surely you don't cover the No Surprises Act. Well, as it turns out, we do. And so obviously it's a little different in an ER. You don't have to have your Visa card. If you're having an emergency, you should call 911 or go to the emergency room. But we adjudicate that with the hospital on the back end and keep the consumer out of it, again, following the law. So I would say sometimes there's a little bit of a like, hey, what are you? We can't figure that out, but it's starting to now that the company started in 2018 or December of 2017. So now that we're about 8 years in, I would say more state insurance commissioners know who we are and what we do and what we're about. And I also think like just in terms of consumerism and transparency and coverage regulations that came out a few years ago in the first Trump administration and have been maintained. I think that's also helped provide consumers better pricing information. It is a little bit easier now when you go to a doctor or you go to a hospital to know what the cost is. And again, a hospital might say, like, this is the charge master. That's okay. That's what they're choosing to charge. And some hospitals have a cash price, but we don't demand one or the other. They're able to charge whatever they want.
So it seems that part of getting something like this off the ground is convincing people in state or federal government that no, this
Yeah.
is something that can exist
Mhm.
and should exist. But then once you actually get it launched,
Mhm.
I assume that part of the challenge is also convincing the main buyers of this product, which would be employers. So how does that look like, right? When
Yeah.
an employer, their HR department or whoever is
Yep.
making the decision to switch
Exactly right.
plans,
Mhm.
they're used to seeing a particular set of plans, right, that fit
Yep.
a certain profile. So
Yep.
how do you get the foot in the door and convince
Yep.
them that this is something that's worth trying?
Yeah, so in this sense, it's very similar to traditional health plans, like a United or an Aetna. We work with brokers, and so we spend a lot of time with brokers in the states in which we're approved to sell the large group product. And brokers take some time to get to know us and vice versa. So in that sense, it's through brokers, but then once you're in that room, as you were indicating with the head of HR for whatever the company is. I think our longest customer is like a 52-person electrician company. And once you're in that room, it typically is because they've gotten a quote from their large traditional insurance or legacy type plan. And let's say, especially in today's world, sometimes I think the average nationally is like 12% increases, but now we're hearing sometimes up to 50 or 56% increase. And if you're an employer with 52 employees, that's a that's a huge line item in your budget. And as a result, they start kind of going, are there other options where we might be able to still provide healthcare because obviously it's a huge benefit for employees. Employees need to be able to go to the doctor if they get sick and their families. And so, is there something that isn't this price? And that's typically where we kind of get a lot of interest in terms of like, okay, well, how does this work? Why are you less expensive? I don't like to say cheaper because cheap implies poor quality when I actually think we have more robust coverage. But how does it work? And so again, then we start spending some time, and you do need buy-in. We're a mission-driven company, and we like to work with people who also believe in what we're doing.
Mm.
Um, we actually, if I could just like tell a short story, we had a really interesting situation with a school district and a teacher in one of the schools. The school district decided to go all in and use Sidecar Health as their insurer. Um, and the teacher did not like this at all. And so she sort of started a movement inside the school district to try to say, like, this is going to be really terrible insurance. Um, she could not be a bigger advocate for our model. She ended up,
Mm.
she had a daughter that had a really terrible sickness and needed a very rare surgery. We paid for that surgery. They also, I believe, paid for her travel because she couldn't find it locally. And in that situation, we basically just sort of held their hand throughout the entire process. And now she says, like, I'm happy to admit that I was wrong about this. And so to your point, like, are there problems or how does that go with an employer? Sometimes there are, a couple of bumps or a question, and people don't like change, right? Change is hard. Do you remember the first time you got into an Uber? Right? It's like, I'm just gonna get in this guy's coming to my house. I'm gonna get in his car and I'm not gonna give him any money and just hope that I get there and get out.
That's
Change
right.
is hard, right? And this is a very similar concept, but Uber's changed how we think about travel. Sidecar Health is trying to change how we think about healthcare. And so it's a slow and steady process. We're not obviously taking over the world tomorrow, but we would like to insure everybody. But we do go, one employer group at a time. We're also moving into the jumbo insurance market. So the large group plan is a fully insured plan, but we're moving into the self-insured market. And so we have been insuring a couple of large companies, Georgia Pacific is an example, where we're a slice offering next to a more legacy type insurance plan. So the employees get to choose.
Yeah, and I definitely like the idea that innovation doesn't only involve offering like a new product, but challenging people's expectations. And like, yeah,
Yes,
and by definition, that's scary, but
it
that's what
is.
change requires.
Yes. Yes. Yeah,
Yeah.
100%. And I mean, it's Rome wasn't built in a day. Like I said earlier, with our guaranteed pricing, we've made changes to the health insurance product over time because as we learn more about a particular market, we also understand how can we make this better for the consumer. Our app has changed significantly so that it's more consumer friendly. But again, with a smaller type of insurance company, we're a little bit more nimble, so we can make those changes in a much more easier way than like a larger plan, like a Humana or Cigna. But it's been really exciting to watch sort of this metamorphosis, and then now to have people say, I don't want to go back to my other insurance plan. I really like having the power and autonomy to decide. And I really like my doctor. People love their providers. When I
Mhm.
first started at the company, I thought the cash back would be the biggest reason that people would want to use a sidecar health plan. It's actually the concept of not having a network because they can go to any provider they want. People feel very personally about their doctors. I do too. I totally get that. And so that's been a really kind of eye-opening, I think, thing for me as well.
So I can pretty clearly see the benefit for the employer, for the individual
Mhm.
patient. I'm curious, to what extent have you seen providers change their behavior, right? Because a lot of them might not be used to
Mhm.
posting prices, especially if like they're like a small practice
Yeah.
or maybe even like a big hospital that's like used to just dealing with big insurers and like they just
Yep.
have like different rates for each insurer. Have you
Yeah.
seen them, like, how have they reacted to this product?
Great question. Yeah, it's a really great question. So I should say too, before we started selling the major medical product, we've spent a lot of time gathering data about what hospitals charge or what doctor offices charge for particular services. So that includes over 100,000 different phone calls, that Visa card that I mentioned at the beginning. Anytime that's swiped, that data gets uploaded into our website. And so that gives us a lot of really valuable information about what people are choosing to charge. So put that aside for a second, but that did kind of help us, I think, sort of progress with providers. I have a whole team of colleagues that spend a lot of time reaching out again in our markets where we're focused, Ohio, Georgia, Florida, Alabama, and Texas. But I have a lot of colleagues who spend a lot of time reaching out to providers in those markets so that they know who we are. When you walk into a hospital and you go, I have insurance, it's Sidecar Health, like that is the person at the front desk. It is not their job to know who we are. And so that can create a little friction. And sometimes hospitals want to be able to, okay, well, if you're Sidecar Health, you're code 64820. And so we do spend some time making sure that they know who we are. We're able to then take their pricing and put it on our website. We have some hospitals that say, um, but we're not, we're pretty expensive. Well, that's okay, right? Like that's your choice.
Yeah, just
Are
let us know.
consumers, yeah, are consumers going to want to go there? I don't know, but we have one system, and this is where, again, like it's when you don't need this government intervention, we have one system who was sort of struggling. Their margins were pretty low. And we said, look, we really think we can help you because when you think about commercial pricing, there's a lot of pricing advantages to why you would want to incorporate more commercial payers into your business. So, and a hospital is still a business, even though they have to take everybody that walks in the door. But with this particular system, um, they learned, oh, like we're losing a lot of maternity care to another hospital system in the next county over. Why is that? And we said, oh, well, it's because they're charging X. And they said, oh, so if we charge a little less than X, we can then take that business too.
Mm.
Sure, if you want to, like, well, again, we're just telling the consumer what all the pricing is. And that was sort of an eye-opening moment and something we had really been, that was more of a visionary. When you start a company like Sidecar Health, you hope that the system sort of has that moment. And so now we're seeing hospitals go, oh, okay, so if I just become a little bit more competitive, again, it's like, why do you go to one grocery store over another? Well, because they have better pricing probably. And so that's been kind of an eye-opening experience. Some providers have said, um, I've been waiting for this. A lot of times when I go to a doctor and I start to explain it, they just go, "Okay, so you're just paying directly." Like I don't even get out psych or health. They just love the fact that they don't have to file a claim.
Mm.
Sometimes it takes a little bit more work where they say like, "Oh, you have to call the billing office." That's fine. But again, like I get to go where I want. And so that's sort of a beautiful thing about it. Um, but with providers, it's, we try to be, I try to think about it as like friend of all, enemy of none. We don't have the friction that a more traditional insurance plan would normally have with providers because they're getting paid immediately. And when you think about that for a provider, that's pretty exciting too.
And what do you think are the kind of trends in this area? Like, do you think that, I don't know, like Mark Cuban's cost plus pharmacy
Mhm.
model, do you think like this is like a model that could potentially take off, or do you think that there's certain kinds of, I don't know, policy or cognitive barriers to
Mhm.
people accepting this kind of model?
Yeah, so I would say so a couple of things about that. So we love what Mark Cuban is doing and being able to share with consumers what the actual cost of pharmaceutical products is. And we want more of those. We want competitors. There should be a competitor to Sidecar Health. That would be ideal, right? Because that means people are getting more excited about consumerism and health insurance.
And it makes you better.
Yes, it absolutely makes us better. Again, sort of going back to like the public school analogy, right? Like competition is pretty good if people have actual choice about where they're going. Um, but in terms of, yeah, so other organizations, I will say, like I said earlier, the transparency and coverage and all the discussion, I think that sort of started in America around that. And now you're seeing more bipartisan interest in trying to promote price transparency policies. Even today in the House Energy and Commerce Committee, they're marking up at the Health Subcommittee four different pieces of legislation that help promote price transparency. The Education and Workforce Committee is doing a little bit of work on this too as it relates to group health plans. We also just recently saw CMS put out a rule. It's the rule that governs the marketplace exchanges, so the ACA plans. But they're used in 2024. They put in a policy that said you have to have a network in order to be a qualified health plan on a federally facilitated exchange. Well, why do you have to have a network? And so this current CMS just put out a rule saying you don't need to have a network. We're getting rid of that requirement, but you do have to meet these nine different clarifications or sort of checkpoints in regulation in order to get certified. And so that's a really exciting moment because it shows that regulators are excited about this concept of innovation and the desire to have more competition in a marketplace where, quite frankly, especially in the ACA marketplace, you're seeing prices go up. You're seeing a lot of plans leave the market, and that's giving consumers fewer choices. And so, does this concept of not having a network help start other innovative plans to promote their kind of model that also doesn't have a network? I hope so. But I think to your question, like we're sort of starting to see that trend. It's slow, but I think when the federal government starts to do it, then other states sort of start to wake up and realize like, okay, maybe there are other ways that are different than the system we've become so accustomed to over the past, 50 to 60 years, I think. But I would say too, we spend a lot of time thinking about how things are drafted. Policymakers are used to drafting things or policies that say network-based insurance plans or group health plans that utilize a network. Why?
Right.
And so I spend a lot of time going, hey, have you ever thought about just saying group health plans? And maybe depending on the policy, maybe it should only pertain to plans that utilize a network, but um, why does it have to articulate anything about a network? How
Right.
about it just be a plan that meets all of the requirements of the ACA or ERISA or essential health benefits or whatever the policy may be? But we spend a little bit of time doing that as well at both the federal and the state level, educating policymakers. And then again, like you get a lot of edits and changes to legislation, I think, for the better.
Yeah, and it definitely sounds like a big policy win for you guys and people in this space that these plans are now ACA compliant. But did you receive any kind of pushback from the incumbent health insurance plans on that? And what, if
Um,
so, what kind of arguments did they use?
Sure. I mean, I would say the larger traditional insurance plans don't like disruptors. I think you
Hmm.
used that word at the outset. They don't like disruptors. But I would say, the friction sort of comes um, more from policy folks who just aren't sure that a plan without a network is going to protect the consumer. And this concept of the unknown, like I was saying earlier, change is hard. And and don't you need to tell consumers where to go? Because obviously they're not smart enough to figure it out on their own. Well, yes, they are when you give them information. So I would say it comes more, there have been a few news articles about, and more from like other maybe left of center think tanks, expressing concern about plans that might not meet all of the qualifications. And so is that going to leave the consumer out to dry? We still, as any health plan does, follow all of the federal laws, including things like maximum out of pocket, essential health plans, being able to make sure that you can go to all different kinds of providers and have access to specialty drugs and things of that nature. So Um, but showcasing that I think is more important. And so there's a little bit more, I'd say, rigor in terms of understanding how the model works.
Yeah, I think that's fascinating because it often when we think of incumbents preventing innovation, we think of it as, well, yeah, they're just trying to protect their bottom line, but often the lack of innovation comes from just simple complacency of the
Yes.
people that are regulating the system. And if that's
Yes.
the case, then that points to the fact that there's probably a lot of movement potentially
Yes.
in this area.
Yeah, I think so. I think you know, here's kind of a I think a shift. Like for example, when the NBPP was a proposed regulation, obviously they were taking comment from a number of organizations. We saw the American Hospital Association um, comment that they want to see more innovation in this space. Obviously, they don't like things like reference-based pricing plans, but should there be price transparency that does promote more consumerism and still protects the consumers and has all of the oversight and accountability that regulators should be putting on those plans, we would be supportive of those kinds of efforts. And that's, I think, a real shift that you're seeing too from the largest hospital trade association organization in the country. So I think that's pretty exciting too. Certainly, there's a lot of nonprofit groups that have popped up. That are promoting more price transparency. But again, I think, we're really trying to focus on our customer base, staying focused on making sure that we're creating the best product for our customers. We do obviously spend a lot of time in Washington and at the state level and various state legislatures. But I try not to, like I said, I really try hard to be sort of friend of all, enemy of none, and try not to be too negative about other insurance companies and we do want to be able to work together, and we are working together in some cases when it comes to more jumbo employers.
Yeah, I mean, I think that really just shows that the really best way to disrupt the healthcare system is not primarily through lobbying, although you have to lobby uh,
Yes.
changes in policies to make your business model even legal to
Viable.
begin
Yeah.
with.
Yeah.
But the real innovation comes from offering something much more valuable to
Yeah.
employers and patients.
Yes. Yes. And now you're seeing, some of the more legacy type plans are, we're talking to them. We have great relationships. They're reaching out going, well, how can we sort of provide more education for our customers? Or should we create a product that doesn't utilize a network? And so that's also pretty exciting too when you see other, and I'm talking about like we call them the BUCAs, Blues, United, Cigna, Aetna, but plans of that nature, kind of figuring out how to maintain their competitive place in the market. And that's great. Like that's really exciting to see.
Yeah, and I'm definitely very excited to see the development of Sidecar Health and other no network plans like that. And I think we'll leave it at that for now. And I would like to thank you, Emily, and thank your
Thank
audience.
you.
And till next time.
Yeah, thank you so much. And really appreciate all the work that you all are doing.
To stay up to date, subscribe to our show from whatever podcast platform you're listening from. To support our show and the Center for Modern Health, you can make a tax-deductible donation at centerformodernhealth.org/support. Thank you for listening.